Welcome, students from Nursing 504 Evidence-Based Practice at the College of Nursing, Washington State University. Anyways, what a great way to have a celebration at the end of the semester to share all of our work. Really appreciate all of the work doing with this team. And as we dived into chronic migraine, I found this to be an extremely fascinating problem. So let's dig right into it. So we chose to use for our model the Johns Hopkins evidence-based practice model, and here they really at the center of it is what they call PET, the practice question, the evidence, and then the translation. So we'll start with our question. I'll show you what we found in our evidence, and we'll talk about how we think we need to translate our findings into practice. Why did we want to choose chronic migraines? Well, more than 4 million adults experience chronic migraine on a daily basis. And there is a cost to that, not only to the quality of life for the patient from the ability to participate in activities of daily living such as leisure, social, and family commitments, but also the ability to find meaning within work and to be able to have a good attendance record at work. And healthcare utilization increases in this patient population. But there's also a financial burden to that, not just even a medical cost that's estimated in the billions annually, but also the cost to employers in terms of sick days and what we pay out in health insurance and other associated related costs. And even the cost to the patient, not just for paying out, but then also having to use disability days and other indirect costs related to their migraine and taking days off from work. So we consulted the literature, and you'll notice the four of us split up. We used a variety of databases from SynHall, PubMed, PsycInfo, ProQuest, Clinical Key, but we also used a variety of keyword searches. We really wanted to break this up. The object being that each of us come back with 10 unique articles, and we then looked at those articles and we rated them, again using the Johns Hopkins toolkit. When we were done with this process, we still didn't really feel like we had a clear answer to our question. And our question really was what non-pharmaceutical interventions are best practices for patients with chronic migraine? And we really, after this process, didn't feel like we had the answer. So we did consult with a medical librarian. Now, we could have used Electra at Washington State University, but given our short timeline right before Thanksgiving, and then also our ability to access some other resources through Kootenai, like the Mayo Clinic and JBI, the Joanna Briggs Institute, we used the medical librarian there, Carly Vesley, and we just asked her to do a quick 5-minute search around the standards of care for chronic migraine and the standards around diagnosis. So we'll dive in using the PICO question. What is the population of chronic migraine sufferers, other than the fact that 84% of them tend to be women and 20% of them will suffer some form of disability? We first have to look at the definition then of what is episodic versus chronic. And it boils down to how many headache days you have in a month. Now, it's this magic number is 15, but not all those 15 headaches in a month are actually going to meet this migraine criteria. At least 8 or more a month need to do that. There are multiple types of headaches, and I'm not going to sit here to describe how to diagnose each one. I simply put these slides together to show you the complexity it takes to actually dive in and diagnose and tease out in these different migraine situations what's going on. And there is one condition to really point out, and that's medication overuse headache. And there is this transition that can occur for some patients between episodic and chronic migraines. It relates to their medication overuse, not because there's a worsening to their condition. And according to the International Headache Society, to really diagnose those patients, we need to remove them from their medications, try to reestablish a baseline. And there's a plethora of other possibilities, and I just used just a few examples here. And so what we're trying to show you today from the literature is that even diagnosing migraine is a complex thing. There are a few risk factors to point out. These are risk factors not only associated with migraine in general, but can also be associated, again, with this transition between episodic and chronic migraine. And we know in the literature that some people have a statistic of about 50% of people with depression will have a migraine disorder, but anxiety, obesity, medication overuse, nutritional deficits, chronic pain disorders, musculoskeletal disorders are all definitely risk factors to consider in your patients. So then the next question really becomes, in our peak call question that we wanted to look at, is what is the standard of care? Before we can affect change, we have to figure out what's the status quo. And there's really, as we look at it, pharmaceutical, when we look at the different types of medications that can be used in either episodic and chronic migraine, it really boils down to what we want to call two classes, or acute management, those kind of as needed medications that we'll use to treat the onset of a headache, as opposed to prophylactic management of medications to either decrease the frequency, duration, or intensity of headaches associated with migraine. But when it really came to non-pharmaceutical interventions, it really was hard to find a standard of care that's really established, and that really just boils down to the fact that it's complex and there's numerous causes for chronic migraines. And for example, if you have patients whose underlying root cause is really musculoskeletal, I mean, they're going to benefit from working with a physical therapist. But if the majority root cause is really nutritionally related, physical therapy is going to be kind of a waste of time in that patient population. So when we look at that standard of care, it seems to really boil down to the medications that you can use across the variety of these different types of migraines. But there's a certain level of complexity that comes with diagnosing and trying to actually treat them outside of just writing them a prescription. So that will bring us to our next steps, but let's finish answering within our PICO question, how would we measure outcomes associated with our patients? And of course, we would like to look at quality of life measures. The MIDAS is a simple 5-item score that we could use clinically. There are another more complex assessment tool we can use, but these are tools that are also being used in the literature as part of the research. So they should hope to translate evidence into practice as we continue to have more findings come from research. And hopefully we can try to support that. Another thing to measure is really the headache diary. And we're going to need to look at creating a team around having the formation of a standardized headache diary our patients are going to be able to use. This will not only improve our diagnosis, but it's going to help our patients to help them differentiate their symptoms. And there's certainly lots of characteristics to consider on that as we build. And of course, the whole object of asking this question was ultimately that we want to reduce medication usage, with our underlying assumption being if we're using less medications and having better outcomes, we'll have a better quality of life for our patient. So, next steps. Well, to really discuss what's our next steps and who needs to be there, we first must look at what is the role of the primary care provider. And the fact is that most migraine sufferers are going to seek care from their primary care provider first. But ultimately, we need to have a headache specialist that's really helping us to confirm these diagnoses related to the complexity of these different conditions. But certainly, nurse practitioners are going to play an important role in coordinating the care between all these different providers. I mean, one of the aspects of that role is going to be assessing how willing the patient is to participate in these activities. If they're not really willing to make lifestyle changes, and that's what needs to be done, we're not really sure that cognitive behavioral therapy, while it could be a very good alternative with a strong evidence base to it, it really does boil down on their willingness to participate. And then there's also the fact that the primary care is going to help them play an important role if there are different providers involved in writing the scripts and making sure that they understand how to use their medication. But as you can see, this is a complex process. So this is taken from a nurse practitioner's journal, and this really demonstrates the complexity that it takes to diagnose and manage migraines, episodic or chronic. But there are certain take-home messages from the American Headache Society that really, this is a publication that they really want patients and taking to their providers and using. And we need to help our patients reduce the frequent uses of over-the-counter medications, and we should really be careful about using opioids and how we're using these and prescribing these for this patient population. So again, our proposal really is to create a migraine navigator and a headache specialist in the office, a primary care provider, undergo that specialized training that can help lead us team through really applying further evidence-based practice. There's going to be a lot of work to translate and a lot of coordination to do, and we're going to really need someone to run point, and we're going to need that headache specialist in the office. So there's certainly lots of different stakeholders that we're going to need at the table that really, went the wrong way, to help that make, from our billing experts to be able to claim revenues to physical therapy, occupational therapy site. So thank you very much for your time. Again, I'll leave this presentation up for a while, so you're welcome to come and claim any of the helpful information you want from it. Thank you.